But what bothers me more is that the hospital itself doesn't have a formal strategy to take care of poor people. For context, I want to share with you just a few statistics. Togo is one of the poorest countries in the world. This is a ranking of 191 countries. The first one is Luxembourg. The last one is South Sudan, for those of you who are wondering. And Malawi ranks 187 out of 191. An article in the Loma Linda University Alumni Association Journal featuring the Longway Adventist Hospital in Malawi makes this statement. It's a bit troubling that the poor of this city cannot afford to be seen at our facility. The cold, hard facts are that if we brought the poor in and took care of them, we would soon have to close due to the inability to pay salaries and buy supplies. And the article goes on to justify the situation. But is this really a cold, hard fact? Should it really be the goal to run a hospital in one of the poorest countries in the world without any burden on those of us who've been blessed with ample resources? Even Loma Linda University and Advent Health, in the sixth wealthiest economy in the world, depend on people's donations to survive. A mission hospital in a resource-limited country cannot provide high-quality care, take care of poor people, differentiate itself from other local hospitals, and truly represent Jesus without some outside support and a worldwide body who stands together to provide the healing ministry of Jesus Christ. And I should be clear, I'm not advocating to offer free care at every Adventist hospital. In fact, most of the patients in Haiti pay at least something. This is important to avoid undermining the local healthcare infrastructure, and important for our patients to have dignity and commitment. Jesus asked some of the people he healed to put forth some personal effort, but it never required very much, and he never turned them away. The transformation in Haiti has required a monumental effort. It was jump-started by one of the biggest humanitarian disasters in history, and many people committed to making it what it is today. We had to independently develop management infrastructure, accountability, and economization. It required major upgrades to the physical plant, and donors helped to build infrastructure like solar power, which decreases our operating costs and allows us to more easily care for the many patients who cannot afford it. We have to produce all of our power 90% of the time. Church leaders need to understand the ailing state of affairs and the pitiful conditions at many of our mission hospitals. And I love the idea of increasing the efforts in the 1040 window across Northern Africa, India, and Asia, where not many Christians exist. But we cannot subtract the resources from parts of the world where people are open to the gospel and where we already have many members who need our support. Our medical school in Loma Linda was established over 100 years ago to train medical evangelists to go into the world. And in the first part of the last century, Loma Linda doctors were starting on average of two mission hospitals a year in countries where people needed us most. And for years, Loma Linda had more graduates working abroad in developing countries than all other U.S. medical schools combined. The College of Medical Evangelists started on a shoestring budget, and many doubted whether it would survive. It's no small miracle that Loma Linda University has graduated more doctors than any other medical school west of the Mississippi. There are over 5,000 Loma Linda doctors in the workforce today, and 19 of them live and work in developing countries where the large majority of people with treatable disabilities and other diseases are suffering. 19. That's less than 0.5%. And just because you may not be a doctor doesn't mean that you're exempt. As much or more than the need for doctors in the healthcare field alone is the need for leaders, administrators, facility managers, accountants, technicians, electricians, nurses, and others.